Section 4, here we are for the last weekend wrap up for Block 4. I'm not going to make this too long because I know that a lot of people are moving on, but I do want to take some time. I do think that there's value here in discussing the things that we talked about over the last week and been reading and learning about over the last 2 weeks. So I do make an effort to try to give you guys something. So in the Combs One Size Does Not Fit All article, I think that's some great literature that really helps break down what can be for a long time was a fairly troublesome diagnosis with lateral epicondylalgia. And certainly I was part of that back in the early 2000s when I graduated. I can't tell you how many times I would Ionto or do cross friction or God forbid an ultrasound. Yes, I even did a couple of those in my day. And what a waste of time that was. And stretch, oh my God, and stretch. And how things have changed, and thank God, right? Because let me tell you, they didn't get better. And there's probably some people who maybe were even doing some of this stuff beforehand. And you can all attest to the fact that that stuff just didn't work. And so this concept of using isometrics as a way to reduce pain, using exercise to increase load tolerance. That was such an eye-opening experience for me. And I think I probably alluded to it a couple of times as we've gone through these videos. But, when patients can understand load tolerance and when you can talk about progressive optimal loading as opposed to rest and stretching and put it in the context of what they need to do, it's such an eye-opening experience in talking about reactive versus degenerative tendinopathy and what tendinopathy is, and that it's not a chronic inflammatory state, and that how we need to go about this. And so these techniques that we use to reduce their pain, whether that's through cervical manipulation or wrist manipulation or mobilization with movement at the elbow, all these things are great opportunities, as we try to reduce that input, right? We're trying to create disinhibition, get those upper motor neuron or upper areas of the brain and the descending pathways to produce inhibition so that we can reduce pain. But understand that that's simply a means to an end and is not the end. Okay, and hopefully that we need to, and as we talked about the about the injection article, and that does not help. And I do believe, I don't know, at least where I am at, the culture that I'm at, that is not used very often at all. I will say that I am constantly in a battle to make sure we have a CHT who's an OT. I feel like it's the call center where these patients get funneled through that I have a hard time seeing them in a traditional outpatient hospital-based clinic that I work. However, I will say that where I work at in a corporate clinic at Target, downtown Minneapolis, I see a lot more of this stuff. And I'll tell you, at first, I love it. I love being able to treat all of these things. And I tell these patients at Target, like, I'm head to toe. But anyways, I know some of you struggle with that. And based on the information that we've gotten, ask yourself, can the OTs really know if these patients are going to benefit from cervical manipulation, and do they appreciate some of the things that we appreciate? I would argue that they don't. Do they appreciate scapular weakness? Do they appreciate, do they apply the same manual techniques, the mobilization with movement techniques, the wrist manipulative techniques? Could they? Certainly they could. I don't know if they have the training, the skills, the motor control. What's the hardest thing about manipulation? It's the motor control, being able to produce that thrust. So something to think about. That's certainly a favorite article of mine. The Fernandez de las Peñas article, Manual Therapy versus Surgery for CTS. I think in the last 4 years, there has been a growing body of evidence to support. Obviously, we've seen a couple of the articles. A growing body of evidence to support conservative management for carpal tunnel. As a general rule, the carpal tunnel surgery is, as surgeries goes, relatively cheap, usually quick, and usually pretty effective. However, obviously, any surgery is a surgery, and it's a big deal and has risks. And if we can treat these people with conservative management and we can reduce their need to have surgery, man, I think that's a home run. And then, the whole point of that, maybe I should, wait, before I jump to the Gonzalez, talking about median nerve glides, mobilizations of the carpal bones, starting even at the cervical spine, working our way down, understanding that CPR. And so a lot of people would talk about, my big thing is the big question that I'm always asking, because it has a high sensitivity, is do you have hand shaking, a numbness at night that causes you to shake your hands to kind of get relief? I mean, that's like the quintessential sign that I'm always looking for. I also am looking for atrophy in the thenar eminence. I'm looking for the concept of needing calipers. I don't use calipers because I feel like if I can get a positive median nerve test, upper limb tension test, and I got shaking at night, which is classically what they have, then it's just a home run. I don't typically use. Well, sometimes I might use Phelan's or Tinel's, but I don't sweat the calipers. But I don't think it would be that hard to implement. Maybe that's laziness on my part. Okay, so moving on. I don't want to take up too much time. Gonzalez Iglesias. So PT for radial wrist. I think the whole point of that article is that you can't just do whatever you want to patients. You have to be thoughtful in your approach. You have to be methodical in your ability to diagnose and to differentially diagnose what could possibly be going on. You have to be continuously assessing and then reassessing what you're doing. And if you're not effective, you better figure that out, what you can do then to help this person. I am constantly pounding on my desk when I'm at the University of Minnesota or when I'm teaching CE courses that we need to be doing test, retest. We need every time. Because not only does it, again, I'll say this again, I know I've said this before, not only does it tell you that what you're doing is correct, but it tells your patient what they're doing. It tells your patient what you're doing is helpful for them. So radial nerve glide is obviously important. I find like that's like whether it's a radial nerve glide or just mobilization along the scaphoid and the trapezium, those are just like money. I feel like it's been my experience that I can get rid of this pretty quick. All right, so comments. So lateral epicondyle management. In some of the handouts that we have with the videos, understanding that pain relief is from manual therapy. We still need to have load tolerance. Talking about the taping techniques. I will say I don't use those taping techniques very often. I don't feel like I have to. I do dry needle, and the pushback on that could be, well, there really isn't a ton of evidence on that, and I'm fine with that pushback. Certainly there isn't a ton, but I do find that I get some pretty good success with the right patient. The problem is that we still don't know who benefits, when they benefit, why they benefit, and we need to do a better job of putting that together. So again, you could push back and say, well, should you be doing dry needling without enough research to back it up? And I certainly could listen to that argument. I do feel like I've had some really good success with probably 7 out of 10 who come in, so 70%. But there are certainly people who don't do well, and I find those to be the ones who are more prone to centralization, have super high sensitivity levels. They just aren't going to do well. And obviously those who have fears with needles. And I guess I've already kind of discussed the carpal tunnel management. Again, median nerve glides with lower cervical spines, side glides to contralateral side, carpal bowl mobilizations, some soft tissue work in the carpal tunnel area. And then as well, I posted a Rincon article to some of you about some soft tissue mobilizations along from the cervical spine, along the path of the median nerve, all the way down into the wrist, that demonstrated with chronic people who had pain up to 2.5 years, I believe, with one treatment. They met the MCID for pain reduction in one treatment that could benefit from more. I think you'll see, it seems like the Peñas of the world, the Spanish folk who are putting out published literature, do seem to like the soft tissue techniques, whether that's in the they also have demonstrated those in the gastroc soleus area for Achilles tendinopathy, but there does seem to be some benefit for some of these things. And the radial nerve entrapment, I kind of already alluded to that. I find that I can mobilize scaphoid, mobilize trapezium, and also for CMC and maybe some radial glides even, and get change, as well as, of course, radial nerve. I have not found, however, successful, and maybe this is just me, maybe others have, contralateral side glides with like radial nerve bias. Not as effective. Although I will do, again, for all of these extremity kinds of symptoms, I will do AP glides, where I'll do an AP glide as opposed to a PA glide, a lower cervical spine, C6, C7, with same side rotation that I feel like does a really effective job at reducing some of that pain. I kind of alluded to that too in the biceps tendinopathy quote unquote diagnosis, that I find a lot of success getting rid of pain there. So that's it. Those are my thoughts. Final comments. Don't forget to do your surveys. I'm going to be emailing out my final comments and grades to everyone over the next few days. I've got some underway. I hopefully will be able to tackle some tomorrow, Sunday. We'll see. Good luck to all of you in the future. I've really enjoyed getting to know you, and hopefully you've enjoyed your in meeting your other learners. I've enjoyed listening and seeing the banter and the dialogue. I've enjoyed I always enjoy different kind of cultural treatment options that people do, sometimes a little bit different things in different clinics or different parts of the U.S. And I always think that's always very interesting. Feel free to reach out with any comments or questions if you have as we wrap up this course. I get residents and fellows and students at times who will send me problems with cases, and I'm certainly willing to help out, lend my thoughts. You can listen to them or not, or if you have any other questions about anything about the residency, about even the fellowship. I think the fellowship is a great opportunity for residents, not right away, but a great opportunity. I have residents and fellows coming through my clinic on a fairly regular basis at this point. If you want to follow me on Twitter, I'm not a big tweeter, if you will, but I like to retweet stuff, and I think going on Twitter and finding information is really, really good. There's a lot of really good people in our profession. All of these people, all of these researchers have a Twitter account, and it's a great way to access their stuff. They're constantly pushing out their stuff, so look for that. So congratulations, you made it. It was great to meet all of you, and I look forward to seeing you in other classes. I every year attend AOMT conference, so if you ever chance to get to that, feel free to tap me on the shoulder and reintroduce yourself. I'd love to meet you all face to face. But otherwise, good luck with your future endeavors. And if I see you again in a course, great. And if I see you at a conference, even better. Take good care. Best of all. Bye.